Thank you, Dr. Porter. With that introduction as to what is the content of an implementation science laboratory, I now invite Dr. David Winchester to give us some insight into multidisciplinary breast program evaluation. Dr. Winchester is the clinical professor of surgery at University of Chicago, Pritzker School of Medicine, Chicago, and he is the Global Summit Program Solving in Healthcare Delivery Program participant.
Thank you and good morning. It's an honor and pleasure to be here. I realize that world soccer is more global than ice hockey, but the excitement here in Chicago today is palpable with the Blackhawks having won the Stanley Cup playoffs for the first time in almost 50 years. So if you glance outside, I wouldn't go outside actually. Probably not safe. So I'd like to spend a few minutes talking with you about the accreditation program here in the United States. We really believe that this sort of effort is a multidisciplinary approach and really requires everyone working together. Medical oncology, radiation oncology, surgeons, and so on have to work in concert and be organized to guide patients through a rather complex system. Mel Silverstein, I think, pioneered in the United States back in the 70s the establishment of a freestanding breast center concept. He observed early in his career that patients with either benign or malignant diseases of the breast entered a system that was really disorganized, fragmented, inefficient, and sometimes took weeks to process a patient through diagnosis and treatment. I would also comment, and maybe Jay is here in the audience, Jay Harness was the pioneer in the 1980s, having established the first academic breast center at the University of Michigan in the mid-80s, and Jay's been another pioneer in this area. The Europeans beat us to the punch. They established their program, European Society of Mastology, several years ago, and that program, as I understand it, has been quite successful and embraced in many centers across Europe. I've had the privilege and honor of being invited to their annual meeting this October in Spain, and look forward to hearing more about their program and telling them about the United States program. Now, there's been a great deal of international interest in the NAPBC. To our north, our Canadian partners, and to the south in Mexico, and then you can see all the other areas around the world where we now have roughly 14 or 15 countries expressing interest. Now, does this mean that the ministries of health of these countries have expressed interest? No. We would hope that they would someday. We exhibit at several major breast meetings throughout the United States and have for the last 3-4 years. And we've had people come forth from these countries seeking information about the NAPBC. We are actually looking, I would comment, we being the board of the National Accreditation Program for Breast Centers, are looking at the prospect, given this interest internationally, of an international component to the NAPBC, whether that be in a accreditation situation with stratification where the resources of a given country would meet the standards that would be possible in that country, or whether a consultative service. We're actually meeting next week, and that's on the agenda. So historically, this goes back 5 years when the American College of Surgeons, which has really pioneered and been a leader in accreditation programs, the Commission on Cancer of the American College of Surgeons was established in 1922. We have nearly 1,500 accredited programs for cancer in general in the United States, encompassing 70 to 80% of all newly diagnosed cancer patients. The trauma program likewise has been around for a long time, and more recently the bariatric program, and now the breast program. So I recall that day, Ben, when we came out to your place in Seattle, having had approval by the Board of Regents to explore this concept, coming to Seattle with a small group of us to provide the first iteration of what we thought were perfect standards and processes, which is now going through 15, I think, iterations. And we did get funding from the college to develop this program, and we started to go out into the community, and we surveyed about 20 centers in the United States. They volunteered to have us come to their centers. These range from large academic centers to very small private practices in rural areas and urban areas. We learned a great deal from those pilot surveys and came back to the table and did our second or third adjustment of what we thought were the best standards and the best components that were required in a good breast center. So having revised all that, we officially launched the program late in 2008, and the first center in the United States was accredited in December of 2008, about 100 by October of the following year, and now we have about 170 centers as of last week. Any good organization should have a mission statement, and this mission statement was developed by our board. We are, in fact, a multidisciplinary consortium of national professional organizations, and we are dedicated to the improvement of quality of care and monitoring of outcomes with patients with diseases of the breast, both benign and malignant. And we pursue this through standard setting, scientific validation, patient and professional education. We have many objectives. The multidisciplinary team approach is essential to coordinate the best care and treatment options. Access to breast cancer-related information, education, and support. A very important part of our program is advocacy. We have one of the major committees on the NAPBC has all the major advocacy organizations in the United States, led by Susan Komen for the Cure, to help us with our website, help us to increase access to this program. Data collection on quality indicators is an important measurement of where we are when we start in 2008 and where we might be in 2012, 15, and 20. We believe that this database should be not like the Commission on Cancer database, which includes quality improvement and many, many other demographic and other data points, but will focus primarily on quality improvement measures. And the first set of quality improvement measures that we have incorporated into the system are the 3 NQF measures, National Quality Forum measures for radiation therapy for patients with breast-conserving surgery, and adjuvant hormonal or chemotherapy for appropriately selected patients with breast cancer. We've just recently identified 5 additional quality measures, and we're going to be incorporating those into our set of quality improvement. For example, one of them is core needle biopsy as the first diagnostic approach for evaluating a suspicious lesion. Another is HER2 new positive patients at least being offered if they're eligible for Herceptin. We have ongoing monitoring and improvement of care, and then, of course, information about clinical trials and new treatment options. It's estimated it takes 15 to 17 years to take the evidence-based outcomes from a clinical trial and have it penetrate into the practice and really have it implemented globally. And one of the things we try and do with both the NAPBC and the Commission on Cancer is act as an educational effector arm for clinical trial outcome information, get out there and educate both the professionals and the community.